We're going to start talking about age-related conditions. So we'll be looking at things ranging from childhood autism to anorexia and bulimia, on up to chronic organic brain syndrome, Alzheimer's disease. And I thought we would start out by looking at a question. The nurse is attempting to establish a relationship with a child who is autistic. The nurse should expect to encounter which of these problems? 1. Hallucinating. 2. Impaired hearing. 3. Bizarre behavior. Or 4. Clinging to others. And the correct answer is number 3, bizarre behavior, which is very characteristic of autistic children. Let's look at another question. To initiate a relationship with a child who may be autistic, the nurse would probably be most effective by using which of these approaches? 1. Playing peekaboo. 2. Having him point to designated body parts. 3. Sitting with him. Or 4. Asking him to tell you a story. And the correct answer is number 3. Remember that children with autism do not relate well to other people, and all of the other choices required interaction with the nurse. So the correct answer is simply sitting with him. If we look at some of the characteristics of autistic children, bizarre behavior, meaning they may do something over and over again. They may be headbangers. They may repeat some action over and over again. They seem to be unaware of others and of the feelings of other people. So they are living in their own world and do not relate to others. It's difficult to say what causes childhood autism. We've been through a history of blaming everything from the way mothers nurtured their children. We simply don't know. It's probably a neurochemical imbalance. We certainly are no longer blaming parents and their relationship with the children for the onset of childhood autism. Now, in terms of relating to children with childhood autism, it's important to try to establish communication, but extremely difficult. These are children that you probably don't want to hold a lot because they don't respond to cuddling. In fact, sometimes they act as if being touched and cuddled actually hurts them. So you would minimize holding. Activities are relatively structured. Many of the children with childhood autism don't even speak. Some will learn some type of a sign language type system. Others simply don't communicate. Another question for us. The nurse is assessing a 22-month-old child who is thought to be autistic. During an interview with the nurse, the child's mother makes all of the following statements about his behavior during the first year. Which statement most strongly suggests that the child may be autistic? 1. He was a good baby and rarely cried when I left the room. 2. He slept very well after each feeding. 3. He spit out every new food the first time I gave it to him. Or 4. He started to walk without learning to crawl first. And the correct answer is number 1. This lack of awareness of other people. Most babies get upset when their parents leave. An autistic child is not very likely to do so. Now as we move on a bit, let's talk about anorexia nervosa and bulimia, conditions that affect primarily adolescent and young adult, primarily women, although men in fact do have this disorder. Anorexia nervosa is an eating disorder in which a person experiences hunger but won't eat, simply refuses to eat. They have a distorted body image and a perception of obesity. They always say that they are just a little bit too fat. Their hips are too big. When they look in the mirror, they see fat, you see skin and bones, and they see too big hips. A number of patients will end up dying from anorexia nervosa. The various studies will tell us anywhere from 10-12% up to 20-25%, depending upon the study. So it's a very serious problem. While it's frequently diagnosed in adolescence and young adulthood, the problem may persist as people go into adult years. Anorexics, you might want to remember, are frequently good children. These are often young women who are achieving in school. They may be doing very well in academics. They may be starring in sports. They usually are obeying the rules. So if daddy says they're home at 10 o'clock, they're home at 10 o'clock. It would appear that one of their major ways of rebellion is what they will not put in their mouth. They may be fascinated with food. So they may be a very good cook. They may know a great deal about food and calories and nutrients. They just don't eat because they perceive themselves to be too fat. They have the distorted body image. And a similar kind of condition is bulimia. Now, a big difference in bulimia, it's an eating disorder, but what happens in bulimia is the person binges. So they say, oh, I can't believe I ate the whole chocolate cake. They compulsively intake a large amount of food, feel guilty, and then self-induce vomiting. They may also use lots of laxatives. They may be excessive exercisers. Anorexics may also self-induce vomiting. So self-inducing vomiting doesn't really separate anorexics from bulimics. But the difference is the bulimics binge and then they purge. So think with bulimia, binge and purge. Let's look at a question. An 18-year-old female is hospitalized for anorexia nervosa. She is 5 feet 7 inches tall and weighs 90 pounds. She describes her hips as too fat. What is the best response for the nurse to make? 1, you are really too skinny. You don't look good this way. 2, look in the mirror. You can see that your hips are not too fat. 3, your hips seem fat to you, but actually you are very thin. Or 4, it is difficult for me to understand how you can do this to yourself. The correct answer is number 3. You will recognize the client's feelings, your hips seem fat to you, and then present reality, but actually you are very thin. Please don't ask this young woman to look in the mirror, because if she looks in the mirror, she doesn't see what you see in the mirror. She sees fat, you see skin and bones. So that distorted self-image even goes to what they see in the mirror. Another question for us. An 18-year-old female is brought to the hospital by her parents. She is 5 feet 7 inches tall and weighs 80 pounds. This evening she is very difficult to arouse and had to be carried into the emergency room. She is diagnosed as having anorexia nervosa. What is the immediate goal for this client? Number 1, state 2 reasons for eating. Number 2, gain 5 pounds. Number 3, eat 3 meals a day. Or number 4, attain fluid and electrolyte balance. Now note that the question asked us the immediate goal, and the immediate goal is number 4, to attain fluid and electrolyte balance. Later on, some of those other goals may be appropriate, but for the immediate goal, it's to attain fluid and electrolyte balance. Another question for us. An adolescent who has anorexia nervosa is stabilized in the intensive care unit and is now on the psychiatric unit. In developing the nursing care plan, which will be of highest priority? 1, weighing her before and after each meal. 2, observing her for 2 hours after each meal. 3, teaching her elements of good nutrition. Or 4, recording her food intake. So we're asked of highest priority now that she is back or she is onto the psychiatric unit. And the correct answer is number 2. We recognize that if she is made to eat, she is likely to self-induce vomiting. So she should be kept under observation for 2 hours after each meal. At the end of 2 hours, if she should self-induce vomiting, most of the food is already passed out of the stomach into the small intestine. We will weigh her, but not before and after each meal. She may be weighed on a weekly basis. By the way, when you do weigh her, make sure that you check her pockets, because she is very likely to put rocks in her pocket or heavy things in her pocket, because we reward these patients for weight gain. And she's likely to want the rewards and perhaps be a little bit dishonest in how she gets to those rewards. You don't need to teach her elements of good nutrition. This young woman probably knows more about nutrition than you do. She just simply won't eat. And our focus is not on food intake. Our focus will be on weight gain. Now I'd like us to move, and we're going to talk a little bit about conditions affecting older people primarily. So we're going to look at chronic organic brain syndrome. And of course, the major condition under this is Alzheimer's disease. Now, some people have said when you look at folks with chronic organic brain syndrome, this little acronym of JOCAM describes some of the symptoms that you see. So they have problems with judgment. They have problems with orientation. They may not know who they are, where they are, what year it is, what century it is. Confabulation. Now I would ask you to think, what in the world is confabulation? Confabulation, you recall, is making up stories to fill in the gaps. So if a patient can't remember what they had for breakfast, they might make a very good breakfast, which wasn't what they were served at all. Or if they can't remember what they did yesterday, they might make up a good story, tell you that their relatives came to visit, or make something very exciting going on. It's not meant to deceive, but it is meant to fill in the gaps. The families of these patients usually tell you they lie all the time. They tell me things that aren't true. Now, there are also problems with affect or mood. Very often their mood is quite volatile, will change from moment to moment. Sometimes their whole personality seems to change, and they may become suddenly quite angry or aggressive in people who normally are not that way. And memory is affected. Memory, now, of course, they lose their short-term memory first. So initially, they can't remember what they had for breakfast, but they may be able to remember what they wore at their 5th birthday party. After all, they've had 80 years to remember that one, and only a couple of hours to remember what they had for breakfast. As we talk about organic brain syndrome, I think we ought to differentiate between two things, between delirium and dementia. Now, delirium is acute, it comes on quickly, and it's reversible. So you might get delirium with a high fever. So this is damage to the brain from a high fever. You could get delirium when you're withdrawing from alcohol, for instance, with alcoholics. But it is reversible. Now, dementia, on the other hand, is a chronic, gradual onset problem that is irreversible, whether it be Alzheimer's or other types of dementia. Sometimes I ask people, if you had to have one of these, which would you rather have, delirium or dementia? My answer is always delirium, because I would like it to be reversible and not have a permanent problem. Now, when we look at Alzheimer's, some people talk about the stages of Alzheimer's. In stage 1, the early stages, there's memory loss. People can't remember names. They can't remember where they left things. So they don't know where the keys are. They don't know where the mail is. They don't know where they left their pots and pans. They just don't know where things are. And they are often become emotionally unstable at this point. The patient may or may not be diagnosed with Alzheimer's in this early stage. At this point, a lot of people are trying to make excuses, denying rather strongly that their loved one may have Alzheimer's. Patients are usually aware at this point that something is wrong. and they're kind of uncomfortable about this. Now, in stage 2, we begin to see more loss of memory. Now, the recent memory, they don't remember the breakfast. They don't remember what they did yesterday. They're disoriented. They may not know what day it is, what time it is, even sometimes who people around them are. They have trouble concentrating, discussing issues, for instance. They may have inappropriate social actions. It becomes more difficult to take people out in public at this point. Now, a couple other things. They may get agnosia. Agnosia means they don't know what an object is for. So they no longer know what to do with toothbrushes or combs or various everyday kinds of objects. They may have difficulty with speech. Apraxia means that they don't know how to do something that they used to be able to do. They no longer know how to tie their shoes. They no longer know how to cook a meal. They no longer know how to do things that they've done for many, many years. This stage can last a number of years. And then by the time they get into stage 3, the disorientation is extremely severe. They usually are very non-communicative at this point. They may also suffer from delusions, which, remember, are false fixed beliefs. Hallucinations, meaning sensory experiences for which there is no basis in reality. They may be paranoid. They may feel people are out to get them, people are stealing from them. They often have agitation. They have, as the disease progresses, some of these patients end up bedridden in a fetal position. So first they lose bowel and bladder control, and then they may end up eventually being not able to walk and move. It's a very, very sad condition. And it may take many years to go through this whole process. If their body is otherwise healthy, some of these patients can live 10, 15, 20 years with Alzheimer as it progresses. It's a very sad disease. We don't know exactly what causes it. There's a lot of theories out there now as to what may cause Alzheimer's. Most of them are just that. There are theories about it. We aren't very good at treating Alzheimer's. Sometimes we give them medications that may temporarily improve their memory, and we keep trying different approaches. But we really don't have all the answers for Alzheimer's disease at this point. There are some studies that suggest that keeping your mind active helps to keep Alzheimer's disease at bay. So if you wanted to encourage older people to do such things as keep reading books, do crossword puzzles, do things that keep their mind active. There are some studies that suggest even if they have the brain changes for Alzheimer's, if they do things that keep their brain active, we don't see the behavioral changes. So on autopsy, we might see brain changes, but behavioral changes don't seem to be there. Until we find more answers, the care of Alzheimer's patients is a real challenge. One of the worst times of day for Alzheimer's patients is nighttime. Sometimes we refer to sundowner syndrome, which means that when the sun goes down, they get very disoriented. And this is when they're more apt to do their wandering and become really totally confused. That's something you might want to keep in mind when you were thinking about planning nursing care or nursing care planning kind of questions. Let's look at a question. The nurse is caring for an elderly woman admitted with chronic organic brain disease. Now, whenever you see that in a question, you can substitute the word Alzheimer's in your mind if you choose to do so. When her daughter visits, she asks, "Are you my maid?" How should the nurse describe the client's behavior? 1, impaired judgment, 2, disorientation, 3, impairment of abstract thinking, or 4, delusional. And the correct answer is number 2. She is disoriented as to person. She thinks her daughter, whom she really ought to know, is her maid. Let's take a look at another question. A client who has Alzheimer's disease is standing near the lavatory door. She has again wet herself. She looks ashamed and turns her head away from the nurse. Which of these responses by the nurse would be best? 1, asking, "Can you tell me why you wait so long?" 2, saying, "I know that this is upsetting to you. Come with me and I will get a change of clothes for you." 3, asking, "Can you think of any way in which we can help you to manage your bathroom trips?" Or 4, sending her to her room to change her clothing. Now the correct answer to this is number 2. Note in number 2 that she says, "I know this is upsetting to you." And in the question it said she looks ashamed and turns away. So we're recognizing the patient's feelings. And then of course number 2 offers self. Come with me. Now number 1 had that why word in there. Can you tell me why you wait so long? First off, why is not going to be therapeutic. And secondly, this patient cannot problem solve, cannot tell you why anything. Choice number 3 asks them to problem solve. Can you think of any way we can help you to manage your bathroom trips? Patients with Alzheimer's are not going to be able to problem solve, so they're not going to be able to do that. And answer 4 said sending her to her room to change her clothing. That sounds almost like punishment. And besides, if you send her to her room to change her clothing, she may not be able to do it if she has Alzheimer's. Let's look at another question. The nurse is caring for a 75-year-old widow admitted to the psychiatric hospital when she began to talk in a confused manner about her husband who has been dead for 7 years. In the hospital, especially at night, the client wanders in the other clients' rooms looking for her husband. What is the most appropriate action for the nurse to take when this woman wanders in the rooms of the other clients? Number 1, lock the door to her room. Number 2, tell her to stay in her room except for meals. Number 3, take her by the hand and guide her back to her room. Or number 4, tell her that she will be restrained if she continues to wander. And the correct answer is number 3. Take her by the hand and guide her back to her room. Explaining things is not going to help, and you certainly wouldn't lock her in her room. So take her by the hand and guide her back to her room. Let's look at one more question. An elderly woman with chronic organic brain syndrome refuses to eat and begins to lose weight. Which approach by the nurse will likely be most effective in getting the client to eat? 1, explaining to her the necessity of eating 3 meals daily. 2, asking the client what she thinks should be done about her lack of eating. 3, telling the client that if she doesn't eat, she will be given tube feedings. Or 4, accompanying her to meals and assisting her in eating. And the correct answer is number 4, accompanying her to meals and assisting her in eating. Trying to explain to her or have her problem solve are not going to be effective with her.